Hi Mark, welcome. So I will ask you, who are you and what are your work?
Okay. Well, I'm, I guess, known for my work in addictions and mostly in the alcohol field. My wife and I have worked as a team for 42 years, and we're both currently professors at Nova Southeastern University, which is in Fort Lauderdale, Florida, which is a little warmer than Norway. And I've had a career that's been very, very interesting and involving in terms of alcohol studies that are on the edge. They kind of push the boundaries a bit of knowledge.
Yeah. So we shall start with the main question, which is, what would you say alcohol dependence is?
Okay. I really prefer not even to talk about dependence because that has many meanings with it. So I just think of it as alcohol problems. The newer diagnostic systems might just talk about them as alcohol use disorder. That's the same as problems. But really, one of the really important things to recognize is you're talking about a broad spectrum of disorders. So you're talking about everything from just a slight problem, drinking getting out of hand now and then, but otherwise not being a problem, all the way to somebody who's so severe that they have alcohol withdrawal symptoms, severe withdrawal symptoms when they stop unless they're medically supervised, and who can die from cirrhosis or, delirium tremens. So that's quite a range and involves many millions of people. And the only reason I emphasize that is because traditional thinking has focused on the people who are most severe, and actually they're a minority of the people who have alcohol problems. I think of everyone, when you say what is alcohol dependence, I think of everyone whose drinking in some way complicates their life. In some way there's some negative outcomes.
So for a doctor that maybe suspects a person with an alcohol problem, what would be the easiest way to define whether a person is inside this spectrum?
Okay, well, I think what would really matter is how you talk to them. I think the more that a doctor would use labels like, are you an alcoholic? The more resistance you're going to get. And likewise, the more a doctor is thinking about anybody with alcohol problems as being someone who's severely dependent, the fewer cases you will identify. Because a lot of the other people I've been talking about, their lives do not revolve around alcohol. It just causes a problem sometimes. And if you approach it that way with the patient, and you're not labeling them an alcoholic, you're not telling them that they may have to stop drinking for the rest of their life, but you're just exploring, is it, you think drinking ever, cause a bit of a problem? Most people are very willing to discuss that. That's not threatening.
How big is the social problem of alcohol dependency or problems?
Well, it's really quite enormous because when you look at a variety of statistics, you can find data on everything from impact on work productivity. For instance, either missing days or going into work with a hangover is going to affect productivity, to it's involved in many domestic violence cases. Now that doesn't mean it causes somebody to be violent, but it's there. And if it wasn't there, maybe they wouldn't have gotten violent. It's involved in a lot of accidents. If you look at emergency room statistics, a lot of the people who come in have alcohol in their system. Did it cause them to fall off the ladder? Who knows? But there's a much higher incidence of alcohol in the system of people coming into the emergency room than you would find if you just went door to door in a neighborhood and measured people. So it's involved with all kinds of consequences: divorces, job loss, criminality. I mean, you name it, and you'll find an alcohol involvement. So it's really, in the United States at least, it's pretty clear that the consequences of alcohol problems are more than all the other substances put together, except for tobacco. And tobacco, the main problems with tobacco are just health problems. You don't get the social problem. But in terms of social problems, consequences from alcohol are, like I said, in the US, more than all of the other drugs.
Is alcohol problems conceived as a smaller problem that it's, or perceived as a smaller problem that is actually is?
Well, if I understand you correctly, I think it is, but that's for the reason that our popular stereotype, the popular belief, is that somebody with an alcohol problem is severely dependent. So the popular belief is this is a person whose life is dominated by the need to drink or by the effects of drinking. And that blinds us to seeing people who have lesser problems, but still very important problems. If you have somebody who, one night a week they play cards, let's say it's a man, one night a week he goes with friends and they play cards, and he drinks heavily, and he drives home, and there's all kinds of opportunities for accidents, for getting arrested for drunk driving, for his wife being very upset with him coming home at 3 in the morning instead of at 10 at night, like you said. Those are serious problems, but we tend not to think of those. We tend to...
Why is that?
I think it's because of two things. I think it's because the cases that are best known to the public and have been publicized in the media and frankly by the alcohol field are cases of people who are severely dependent. And I think the other reason, quite frankly, is because the implications of having a problem that severe are kind of scary to someone who just has a bit of a problem. So we'd rather say, okay, if you have this kind of problem, you're this kind of person, and all these things apply to you. And if you're not this kind of person, nothing else matters. We just forget about everybody else. And that's had a big consequence for society.
So is alcohol problems often seen in combination with other diseases? Yeah. There's, well, of course, with other health issues, again, I'm only really familiar with data from the United States. But data from the United States suggests that about half of the people in a hospital, for whatever reason, that there's some alcohol relationship to what they're being treated for. In terms of mental health disorders, it's pretty clear that you get comorbidity. What we basically tell our students, we train doctoral students in clinical psychology, and we tell them, in the general community, comorbidity is not that common. But if you're in a mental health setting or in an alcohol or substance use program, it's very common. Probably half of the people you see will have another mental disorder as well. Now, partly that may have to do with, at least in the US, with who gets to treatment, because it tends to be the most severe cases that come in. And quite frankly, if you're comorbid, if you have not just an alcohol problem, but you also have one or two other major mental disorders, you're probably going to feel much more of a need to come in and seek help than somebody who just has an alcohol problem. But it doesn't matter. We tell them, you know, if you're going to be in an addiction treatment program or a mental health program, you are going to see people with comorbidity.
Is it important to understand the interaction between alcohol problems and other diseases?
Well, it's a very interesting question because what we have is a lot of information on the prevalence of comorbidity. So we know it's there. One of the reasons is it's easy to do studies like that. You come in, you interview everybody, you go back to your office, put it in the computer, and you write papers. In terms of treatment, there's actually a very small literature on treatment of comorbidity, and it tends to be highly specific. So what I usually tell my students is to use their heads. I mean, they're clinicians. To the extent that the problems seem to be what we call functionally related, you probably have to address both things to make any progress. So if somebody has a severe anxiety disorder and they're drinking as a way of minimizing their anxiety, it makes sense that if all you work on is the drinking, you're probably not going to get very far. You need to do both things. But you can have people who have certain types of personality disorders, for instance, like antisocial personality. That can exist pretty independently from an alcohol problem. And it's not clear, like I said, from the literature, it's not clear. There are three suggested ways of treatment. One is sequentially, so you treat one thing and then treat the other. Another way is parallel, so you treat both things but in different places at the same time. And then the ideal thing would be integrated treatment. One program treats everything. It's nice to talk about that, but when you actually come to the models and controlled trials, there's very little to suggest. So it's really a matter of, I hate to say it because I'm a scientist at heart, but it's a matter of using good clinical judgment. And you know, there's a lot of things in clinical practice you have to do that with. We have research on a lot of things, but there's a lot of important things we don't have enough research on, and that's one of them.
You touched on this previously, but is there a difference between the popular understanding of alcohol dependence versus the scientific understanding?
I think there's a great difference. Certainly within the specialty treatment area, there's a real lack of understanding that there are many people who don't have severe problems. But I think that carries over to the general population. I think we have a conception of, you know, there are some people and they're called alcoholics and they do this, this, and this, and you need to do such and such with them. And don't think about the broad range. And it's just part of, it's part of the culture.
So also this is touching upon what you suggested earlier, but what is the most common misconception among people?
I think the most common misconception is that the only people with alcohol problems are people who are severely dependent. People who, if they stop drinking, will go into withdrawals. People whose lives totally revolve around alcohol.
And this is a category also, but how big is this part of the spectrum?
The data suggests it's a small part. The data suggests that, well, if I use data from the National Institute on Medicine, which is part of the National Academy of Sciences, they estimated, their estimate may be a little high, but they estimated that about 20% of people have alcohol problems. they estimated that about 4% within that have severe problems, and that the other 16% have problems that aren't severe. So in other words, for every one person with severe problems, 4 people with problems that aren't severe. So that's a pretty large group of people to ignore, to not pay attention to, especially because problems can multiply. You know, if you don't pay attention to problems, sooner or later they can become much bigger.
Mm. So let's go a little deeper into the popular understanding. And the next question is it wrong to think of alcohol addiction as a character flaw in the alcohol-dependent person?
Well, I think that's a myth that was gotten rid of a long time ago in the research. In terms of searching for an alcoholic personality, what you find is after people have developed very severe problems, they have a lot of things in common. They have low self-esteem. Well, if you've almost ruined your life by drinking, you don't think very well of yourself. There are lots of things like that. But every time they've tried and find things, personality characteristics that predict a person's going to develop alcohol problems, you don't really find evidence for it. So the idea that that it's somehow a personality flaw really has been, we use the term debunked. It's just, people don't really believe that much. Now I think, certain personality characteristics may put a person more at risk, just for lots of things. If you're not that concerned about consequences, so people who have like an antisocial personality, they may be more likely to take risks that involve drinking, that involve other drug use, that involve, delinquency from school, that involve crime. But I don't think that's a big issue. I think with most people who have alcohol problems, it's not because it's not that personality is something that causes that.
But how can this perception among people affect a person with an alcohol problem?
Well, I think there's a huge stigma. And as much as we've tried to change that, I don't think we've done a very good job. It still isn't somebody, you won't find anyone who says, I wish I was an alcoholic. I would be so proud if everybody thought I was an alcoholic. They don't. So I think that by making it something special and separate, if anything, we've encouraged the prejudices. We've encouraged the, kind of, it's like they used to do in the old days with people who were mentally ill. It's like, get them away, put them in an asylum somewhere, and make sure it's out of the city, and don't bother us with them. And I really think, we need to come to grips with alcohol problems are very common, and many of them can be dealt with pretty easily. Just like there's a lot of health problems that are common that can be managed pretty easily. We need to break down the stereotype.
So, but can alcohol dependence be compared with a disease?
Well, there's a very interesting history of the disease. A lot of people call it a disease, but most of the time when people use that term, they're just using the term. They don't. The person who created the disease concept, Dr. E.M. Jelinek, is a very smart fellow, and if people read his book, The Disease Concept of Alcoholism, what they will find is that he basically says when a person is physically dependent on alcohol and will suffer withdrawal symptoms if they stop drinking, they're in a departure from normal health. And we could then call them ill, diseased, whatever we want. He preferred disease because the whole idea was to force physicians to deal with them, because at that time it was thought of as a social problem, and if somebody was out on the street, intoxicated, they would be put in jail in what we called a drunk tank in the U.S. and Canada and other places. And some of them would die when they went into withdrawals. It wasn't treated. They would have seizures. They would have DTs. They would die. So I don't have any difference with, I agree, when somebody's physically dependent, they aren't a departure from normal health.
And
Now, Jelinek also said once they're not physically dependent anymore, they're not diseased anymore. But see, the common idea is nothing like that. The common idea is that it's something like, tuberculosis or an infection or something like that. That I have a lot of problems with because it doesn't fit. It's just not the characteristics of the disorder. And it gets in the way. I think when you call something a disease, there's a lot of other meaning that comes with that probably isn't helpful for attracting people to treatment.
But does this mean that the 4%, is that the part of the spectrum that it's useful to view as people with a disease?
Well, it's a question whether it's useful, but I think you can. I mean, basically, when somebody's physically dependent on alcohol, I think that's important to know because it tells me something. As a clinician, it tells me this person probably has a long drinking history, because to be physically dependent, you typically have to consume from 26 to 40 ounces of whiskey or its equivalent per day, every day. You have to do that for several days to have withdrawals. So most people take several years before they can consume that much in a day and do that every day. So it tells me a person has a long history. It tells me the person has had to design their life to revolve around making sure they have their alcohol, making sure, so they have to be in circumstances at work or home where they have to have some alcohol frequently or they'll start shaking. So it tells me that. It tells me they probably have other health problems. They may have, some liver dysfunction, not cirrhosis, but, their enzymes may be, they may have a fatty liver, they may have hepatitis. So it tells me a lot to know that a person's been physically dependent. Whether it should be considered a separate category, I don't know, because technically it's all just a continuum, and the only place that's probably important that way is sometimes the first time a person gets tremors, that to them is like the signal. It's like they've known for a while that they might have to change, but it's like this is it, and this is when I have to stop. And then other people, of course, it's you know how to treat this. You have another drink, and you calm down. So again, it depends on your social circumstances, your values, a lot. But I think, like I say, severe dependence I find very meaningful clinically, but as to whether it's a separate category, I don't know. I don't find it necessary to think of it as a separate category myself. I just think of it as the severe end of the spectrum.
So this also we touched upon briefly. But what is the real difference between a person with a dangerous high alcohol consumption and an alcohol addict?
Okay. A lot of our social problems are related to alcohol intoxication. So that's the high blood alcohol level. When you get people who are addicted, so the people who are they're physically dependent, much of the time they're not intoxicated. Much of the time they're feeling somewhat normal. It's because what has happened is their body, and in particular their nervous system, has adapted. It's gotten used to the normal state is having some alcohol in them. And when they did studies on this back in the early 1970s with people who'd been chronically, severely dependent, and they gave them access to alcohol, they found that most of the time they kept their blood alcohol level somewhere around 0.20 to 0.25, and they weren't really intoxicated. They were just getting along. And then every now and then they'd go up to maybe 0.32. So that would be, you know, you get a little higher and you feel intoxicated. But most of the time, you're not going to get people who are physically dependent coming into the emergency room that often because they fell off a ladder, because they're very used to doing things. Their body works against, it's what we call tolerance, and their body kind of normalizes it. That's why when they stop drinking, their body feels abnormal and they have to readjust. People who aren't used to drinking heavily, say somebody in their 20s and they get really drunk one night, they decide to fix the heater or they decide to drive home. They're the ones to worry about the most. And I have, when I teach this, I use examples. We had a whole flight crew, a plane that flew, the cities won't matter in the United States. It was from Fargo, North Dakota to Minneapolis, St. Paul. They flew perfectly. The pilot had been seen to have 19 drinks in the bar before they went out to fly the plane. He had a blood alcohol level of 0.13 after they landed. So he was very intoxicated in terms of blood alcohol level. His defense in court was that he was an alcoholic, and where most people would have been very impaired at that level, he was essentially normal. Now, the court didn't accept that, but the fact is, you had a flight crew, and the other two crew members were intoxicated too. They flew the plane perfectly, and there were a lot of things they had to do, and so it wasn't just an automatic pilot. They flew it perfectly because they're very adapted. You had somebody who's not used to drinking, they have the same blood alcohol level. You don't want to be on that plane. I don't want to be on the plane with the crew that's used to drinking either, but you get my point. Somebody who's used to drinking a bottle of whiskey a day is going to be more coordinated on most common physical tasks than somebody who's had a lot of alcohol and isn't used to it. That's when you've got like somebody 18 or 19 who's had a lot to drink, you're looking for trouble.
So then we have the next main question.
Right.
That is, what is the most common treatment option today for a problem, for a person with an alcohol problem?
Okay. I can really only speak from my experience in the United States and a little experience in Canada, but that was very different because of where I was at. Although I understand there are a lot of similarities with Norway. That's what I've been told in the little time I've been here. In the United States, the predominant type of therapy is 12-step programs. And that's probably upwards of 90% of all the programs. So it's one treatment for everyone. Whether your problem is just a little bit or your problem is tremendously severe, one treatment. It involves labeling yourself, accepting that you're an alcoholic, and it involves giving up alcohol for the rest of your life. In most programs, it would involve also attending AA meetings for the rest of your life. Now, for some people, that works, but there's two problems. One is very few people ever come for treatment in the United States. It's less than 15%, and some data suggest it's only about 8% of people with alcohol problems who ever present for treatment. And the other problem is, if you do present and your problem is not severe, you typically drop out very quickly because you don't agree with what's being put upon you. And the demands just seem out of line. It seems like too many things you need to do for the type of problem you have. So that's a very serious problem that we don't have. We have lots of research showing what kinds of programs would be helpful, but that's research. When you get to clinical practice, It's virtually all the same.
So, would you say that the 12-step program is effective?
I don't think you can say that for a few reasons. I mean, there's only one type of 12-step program ever been really evaluated. And that's not exactly a 12-step program. It was called 12-step facilitation, and it was used in a federal study. It was based on the 12 steps, but it's a very specific 12-session outpatient program. And what they found in that study, they basically found no difference in effectiveness between, I mean, all the groups in the study showed a substantial reduction of drinking after treatment. But they found basically no difference between 12-step versus the other two treatments were another 12-session program that was cognitive behavioral coping skills. And the other treatment was 4 sessions of what they called motivational enhancement, which was basically, so that was very interesting because 12-step, the whole philosophy is to convince people that they're powerless, that they're different, and that they need to stop fighting it. Motivational enhancement, the whole philosophy is to get people to take charge of their lives. And you come out with no difference in effectiveness. To me, that suggests differences in treatment philosophy are more important to clinicians and researchers than to our patients. What's going on with our patients is something else. And that's where we need to focus our efforts, is on what else can we do to help. But in terms of 12-step itself, that's the only test. I mean, I hate to say it, even though it's the predominant treatment, it's virtually unevaluated.
Yes. So, though the effect of the treatments are not evaluated much, maybe you have some numbers on how many people with alcohol dependence that are treated or tried to be treated with the today's program?
Are you meaning how many have good outcomes, or are you meaning how many actually
How many people are treated in some form?
Well, like I say, the estimate is somewhere around 8% or 8 to 10% of people who ever access treatment. The interesting data from the US, and these actually replicate data, there were similar data that came out in Canada a few years before the US study, shows first of all that most people with alcohol problems never go to treatment. And secondly, that most people, about 3/4 of people who recover from alcohol problems, do it without going to treatment. And as you might expect, it's a self-change recovery, as we call it, is much more likely to occur for people who have less severe problems than people who have severe problems. It's that way with every health problem. You know, if you have somebody who has a very severe, whether it's a physical illness or a mental disorder, if it's very severe, the prognosis, the likelihood that they'll get better is much less than somebody who just has a little bit of a problem. But like I say, from the US, the interesting data are that hardly anybody goes to treatment, and that the vast majority of recoveries are from people who haven't been in treatment. So somehow we're not doing something right. You know, if this were a business and you were only reaching 8% of your market, people would say that was an awful business, that something was wrong. Somehow, in the United States at least, people are just happy with that, but they shouldn't be.
What would you say that the goal of the 12-step or the mainstream treatments are today?
Well, the goal is very clear. The goal is always abstinence, not drinking at all. And that basically comes from the big book of Alcoholics Anonymous, which was written back in the 1930s. And quite frankly, I mean, for most people who have severe problems, it makes sense as a goal, and they will even tell you that. The problem is reaching that goal. Having a goal is fine. Getting there is very difficult. But the problem, at least where I come from, is that that's the same goal. If somebody comes in and they just have a little bit of a problem, it's all the same thing. It's still what you have to do. And the evidence is quite clear that for many of those, that's not what they have to do at all. But the goal of traditional treatment are all what we call abstinence oriented. They all have a goal of never drinking again. And that's one of the things that keeps people from going to treatment.
But what would you say the weakness of this goal is?
Well, I think there's a couple of problems. The main weakness is it does not attract the majority of people who have problems who could benefit from some treatment contact. So that's the main weakness. Another weakness is that it tends to be, it tends not to recognize improvement. So it has a very black and white kind of outcome. You're either clean and sober or you're drunk. And it doesn't recognize a person who's been drinking heavily almost every day of the past year. If they're able to change things so that this year only maybe 10 or 15% of the days they've been drinking heavily, and the rest of the days they either haven't been drinking or they've just had a little. According to mainstream treatment, it doesn't matter. They're a total failure. But the fact is, they're really a huge improvement. If it was a family member of yours, and they went from, drinking heavily every day to drinking heavily only maybe one day out of 10, yeah, it's not an ideal outcome. It's still not great, but they're much better. And in traditional programs, that doesn't. As soon as the person has one drink, this is the way AA is. You have, you may have had. I actually had a patient who was this way. She'd been in AA for 19 and a half years. Then she confided to me. She told me in treatment that there had come a time when she'd had a drink, and it turned out it had been 19 years since she'd had a drink. And I said, "What happened?" She said, "It was awful. It wasn't anything like it used to be." I said, "What did you do?" She said, "I poured out the bottle and threw it out." I said, "Well, who else have you told about this?" And she said, "Are you crazy?" She said, "You're the only one, and that's because I know you have to keep it confidential. That's part of your ethics." She said, "If I told my friends in AA, I started day one again. After 19 and a half years, having one drink, and she would start at day one." And she said, "You know what? I'm coming up on my 20th anniversary. They're going to have a drink celebration. I'm going to get my ring or whatever for 20 years of sobriety. So I'm not going to give that away because I had one drink, nothing happened." But that's a bad side of things. That's what I mean about not recognizing improvement. It would be that 19 and a half years of not drinking meant nothing because she had one drink. And the fact that she had one drink and then threw away the bottle would mean nothing. And that's pretty severe, really.
So also in the current treatment context and the 12-step context, is this treatment good for early intervention and treatment?
Well, it should be obvious by now that it's not. It really scares most people away. Most people who have problems that aren't severe don't even think about going to that kind of treatment because they know the same stereotypes as everybody else. And it's like, well, yeah, it may be a problem, but it's not that kind of problem. If they do go to that kind of program, what you find is, a very substantial dropout rate. They make a visit and then they come back and say that was a mistake. Or a lot of times they say, maybe someday that's what I will need, but not now. So it's a real problem.
What would be the benefits of having early intervention and treatment?
Well, I think the benefits are obvious. A lot of people, well, we've already discussed a lot of the social cost of alcohol comes from episodes of intoxication and from people who aren't severe. Obviously, like any other problem, the quicker you catch it, the smaller it is, the easier it is to solve. So I think the benefits would be great if we had appropriate services available, because it would be like fixing a car where in one case you have to change the whole engine, whereas in another case all you have to do is do what we call a tune-up. You just have to change things a bit, and now it drives fine. You might find a lot of people where a little tune-up is all that they need to straighten out their lives. Whereas otherwise, without that, some of them, not all by any means, but some of them, depending on your life circumstance, it will get worse and worse. And then you end up with severe problems. But early intervention, I mean, every health area, early intervention is recognized as valuable for lots of reasons. And it's recognized in this area as valuable, but appropriate services aren't available. So early intervention would be forcing somebody with small problems to come to a traditional program and finding some way to keep them there, to somehow convince them it was right. It's instead of designing programs that are more appropriate for them, So it hasn't worked.
Mm. So how should an effective treatment look the way you see it?
So this is a fantasy, right? This is in a world that doesn't exist.
Sure.
I think you would have if I can say, a spectrum of treatments. Just like with the problem, starting with very mild, going to more intensive. You would have, starting with ways of trying to, we call it promoting self-change, of trying to get people to realize that they might be able to change on their own and to try that. And then the term that started to be used in the States now, at least at the government level, is facilitating self-change. So finding ways to give people some tools to help them out to do that. Because each part of the way, and the overall concept, which is familiar in other areas of health, but isn't used in substance abuse at all, is called stepped care. So like with blood pressure, if your blood pressure's up some, but it's not so bad that you're going to have a stroke or anything, but it's at a risk level, your doctor's going to ask about your diet, going to ask about your exercise, maybe get you to cut down your salt, maybe get you to exercise more. For some people, that will work. For them, all they have to do is just keep monitoring, make sure it doesn't get high again. For other people, it won't. And you step up the care either by doing more of the same or by doing something else. The more of the same might be, maybe you find out the person didn't really change their diet that much and they weren't really exercising. So you get them to actually do it more. Or maybe they were, and maybe you go to a mild form of medication. You do things eventually. Now some people, of course, nothing's going to work. Some people are going to need maybe a more invasive procedure. Maybe you find out that some of their arteries are being clogged with lipids and they need some kind of invasive procedure. But that only gets done on the people who really need it. So the whole idea would be, after facilitating self-change, you'd go to some kind of very brief interventions, typically something like primary care physicians could do it. People do it right now. They do it in emergency rooms and such, up to outpatient that can be just a few sessions, or it could be more. All the way up to as the problems get worse and worse, there's a concept that at least at the government level and the research level in the States is considered good, called continuing care. And that's basically where the person is so bad that you establish a continuing relationship with them. It's kind of like somebody with severe schizophrenia, who sometimes they'll function okay for several months or even a year or more, and then they start to get stressed and they start to decompensate. They start to have symptoms, and you get them more involved in treatment, and they stabilize, and so they go in and out. And you probably, with the most severe cases of alcohol problems, that kind of model would probably fit as well, that they get everything together and do fine for a while. And then, problem recurrence is a very common phenomenon among people with severe problems. And it makes sense to actually have a treatment model that accepts that. It doesn't expect it, so you don't want to give somebody a self-fulfilling prophecy. You don't want to give somebody the expectation that they will relapse. But you need to be prepared, if they do, not to punish them for that, and to help them get back to good functioning as soon as you can. So I would say a spectrum of services that starts at the least intensive, that might get the job done. And everything after that depends on how the person does. Because each step of the way, some people are going to be fine with it. They're going to respond okay. And with them, we don't have to do more. We just have to kind of monitor it. So from a public health standpoint, saving healthcare dollars, that's a much more efficient way of doing it. And the way we treat most health problems. We just don't treat, alcohol problems don't get treated that way, but most other health problems do.
What would the pronounced goal of your treatment?
Well, I mean, a couple of things. If I had it my way, I would do like we do in our clinic. We have people choose their own goal. We give them information. We give them, if there are any medical contraindications, if they have diabetes or they have gout, I don't know if that's the right word in Norway, but there's certain medical conditions where you shouldn't drink alcohol. If they have so we call those contraindications. If there are, sometimes there can be social contraindications if the judge says, I order you not to drink alcohol. But we have people choose their own goals because the research is pretty clear that that's what they do anyway. The idea that I can tell you what to do and you're going to go do it, I think of that as a therapist illusion. You're the one who decides. The best I can do is give you information. The evidence is pretty clear that most people who have low-level problems that aren't severe, will start out trying to reduce rather than stop entirely. And it's also pretty clear that most people who have severe problems will try and stop totally. Now for them, when you talk about reduction as a strategy, for them it's much better to think of it in terms of harm reduction, because they're a severe case, they're likely to still have problems. The question is, will they have fewer problems if they're seeking to drink less than if they're not seeking to drink at all? And I know it seems not to make sense, but there is some evidence that people seeking to not drink at all drink a little bit more than people seeking to reduce their drinking. I can't explain it at this time in terms of what the mechanisms are, but there's some pretty good data suggesting that goes on, and that somehow trying to restrain oneself makes it more likely that you'll drink.
So today there are not really any treatments in place for the common health personnel to implement But you have such a concept that is named the reduction concept, which is very similar to what you just told me about.
Yeah.
But how would health personnel today treat patients with the reduction concept?
Well, this is already happening a bit in the United States. It's not happening at alcohol specialty programs. They're very 12-step, they do their thing. But for instance, the government a few years ago approved payments for physicians in emergency rooms to do what they call brief screening and intervention. And what they do is, if a person comes in and, you know, let's say there's alcohol involvement, they'll talk with the person in a motivational interviewing way. So they won't lecture the person, but they'll just ask, you know, can we talk about your drinking for a couple minutes, and, you know, what do you like about it, and, you know, what are the less good things, and then they'll just suggest that the person reduce their drinking. They won't suggest that they stop. They'll suggest they reduce it, and that is defined as typically taking somewhere from 3 minutes to 15 minutes. That's very quick in the emergency room. It's emergency room physicians doing it. The reason they're doing that is because when controlled studies have been done, they have found that people who get that kind of intervention, as quick as it is, over the next 4 years, they have fewer emergency room visits, they have less treatment for alcohol-related health problems, and they have fewer social consequences. So in the US, the Medicaid, the government part of service that provides service for low-income people, they estimate that if all emergency room physicians did this, they would save $500 million a year because of the health consequences. So that's one of the ways it would be done. I mean, we're really not talking about alcohol specialty programs as much as we're talking about general practitioners, primary care physicians, nurses, psychologists, social workers, psychiatrists, and doing fairly brief treatment because the evidence suggests a lot of people will respond to that.
What would your message be to health personnel that needs to treat a person with an alcohol problem?
I think there really would be two messages. One is we need to change our concept of alcohol problems to be consistent with the data and to recognize that there's a full spectrum of people and that there are many people who have problems that are not severe, but that still are problems. The second thing is to understand that in most of those cases, they can treat them as well and probably better than a specialty program, because most specialty programs are going to be not just intensive, but they're going to be confrontational. They're going to try and label the person. And people who have not severe problems don't like that. But they'll listen to their doctor. Their doctor suggests, you know, maybe you need to, would be a good idea to cut down a bit from what you're telling me, or even says to them, what do you think? You know, and the person might say, well, I think I probably should cut down a bit. And then you could discuss ways of helping it. Some people might want to come for treatment. Some people might want medication. Some people might say, you know, I'm fine. I'm able to do it on my own. But I think the big shift would be getting to kind of the general practice level, not having it as something separate from everything else. That, I think, would make a huge change in the field.
Mm. So let's just take this final question. How do you feel the political landscape around alcohol treatment are today?
Well, I can only speak for the United States. In the United States, the political landscape is that 12-step programs totally dominate the field. So in terms of efforts to get specialty programs to change, people have mainly given up on that.
I think what has been making progress in the U.S. is the National Institute on Alcohol Abuse and Alcoholism, for instance, has taken the kind of approach I've been describing of going to general practitioners and more saying to, if they were meeting with a group of primary care doctors, they would say, who should be treating your patients with alcohol problems? You should, because in most cases you can. But I think if you were to, this is all kind of below the political level. If you were to try and have some national campaign or have media coverage, the politics would be fierce. And because traditional people, it's not, you know, for many professionals, it's, you know, it's a science practice kind of thing. For traditional people in the alcohol field, it's much more like a faith. It's much more like the Ten Commandments. And to suggest changing it a bit, it would be the same reaction you'd get for somebody in a church if you suggested changing one of the commandments. You know, they're not going to be receptive. So I think that's a main issue. I don't know if it's different in Norway, and if you know, if you could make now it may be different for one reason. In the U.S., we have this very complicated system where some people have no health insurance, other people have health insurance because for your employers. A lot of people make money out of the healthcare services. In Norway and most other countries, the government pays for most healthcare services. So there's a natural emphasis on a public health approach, because if things are very expensive and not working, somebody's got to pay for them, and somebody is the taxpayer. And politicians who raise taxes don't get reelected. So there's probably more hope in countries that have government-funded health care because they need to take account of the evidence.